So, good morning, good afternoon, good evening, everyone. Thank you for joining for this highly anticipated webinar on the management of blood cancers in the intensive care unit. This is an important and dynamic topic that bridges expertise of hematologists and intensivists, and it's essential for improving outcome in some of our most critically ill patients. It's my honor to introduce our distinguished speakers, Dr. Elie Azoulay, a world-renowned expert in intensive care medicine and hematology. Dr. Azoulay is professor of medicine and head of the medical intensive care unit at Saint-Louis Hospital in Paris, France. His groundbreaking contribution to the field have reshaped how we approach critical care for patients with hematological malignancies. Dr. Azoulay has provided some important insight into the management of life-threatening complications in patients with hematological disease, from acute respiratory failure to sepsis and beyond. His commitment to the multidisciplinary collaboration and innovative care has led to better survival and quality of life for our patients. Today, Dr. Azoulay will guide us through best practices, emerging evidence, and clinical strategy for managing blood cancer in the intensive care units, a complex intersections where precision medicines and rapid decision-making is indispensable. We are fortunate to have this opportunity today to learn from one of the most foremost leaders in this field. Following the presentation, there will be time for questions, so please feel free to send some questions to the chat during the presentation of Dr. Azoulay. Once again, thank you for being here today. And with no further ado, please join me in welcoming Dr. Elie Azoulay. Dr. Azoulay, the floor is yours.
Thank you very much, Florent. Hi, everyone, wherever you are. Good afternoon, good evening, and maybe good morning. Blood disease in the ICU. Well, this is the topic of many people all over the world, and we are a group of ICU specialists dedicated to the care of hematopatients in the ICU. So these are my disclosures, and I want just to emphasize how much ICU is one of the mandatory steps for many patients with hematological malignancies. Of course, in patients with newly diagnosed malignancies, tumor lysis syndrome, infiltration of the lungs, the kidneys, the liver, and many other, compression and toxicity are routine risk factor for ICU admissions. And for patients who are already treated, we know that neutropenia is one of the main risk factors for septic shock, but also for very, very specific clinical vignettes. This is a study that we did a long time ago that was reporting more than 1,000 hematopatients admitted to the ICU in a number of centers in our group. And very clearly, you can see that sepsis and acute respiratory failure are the main leading causes for ICU admission. And you have there a number of reasons why those patients are at risk for ICU admission. It can be pneumonia, which is, of course, always the first organ involved in these patients, but it can also be acute kidney injury and septic shock. Interestingly, I would like to start by a study that was published 2 years ago in the ICU literature on a database coming from Ontario, and my colleagues Lavina Munchi and Bruno Ferrero from Toronto have really pushed the concept that ICU has to be considered as a mandatory step for patients with malignancies. This is the case for, and you can see here the cumulative incidence of ICU admission in patients according to underlying malignancy, AML, ALL, lymphoma, and myeloma being the first providers. We also know quite well the timing of ICU admission and the two situations where the patients are at the stage of diagnosis as well as during neutropenia. So you can see that up to 20% of the patient will have an ICU stay within the year following the diagnosis of hematological malignancy. Acute respiratory failure is 50% of the cases, but kidney injury and sepsis are also leading to a number of ICU admissions within the year, but of course within the 100-day that follow diagnosis of hematological malignancy. For every single disease, AML, aggressive lymphoma, ALL, MDS, you have the incidence of ICU admission, the main reasons for ICU admission, as well as ICU and hospital mortality. I believe that this is something that should be kept everywhere, just to be aware that if we build an ICU in a hospital where there are hematology wards, we need to consider that up to 20 to 30% of the patient will require an ICU admission. And of course, this is in Ontario. The same numbers are in France, in Spain, and in Italy, making clear that these numbers should be considered as the reference. And again, here for multiple myeloma, we can see that about 14% of the patients will get to the ICU, and for about the same reasons than in other hemato patients. Let's take the example of this 47-year-old man coming to the ICU for acute respiratory failure exactly at the time where an AML was diagnosed. AML was diagnosed because of multiple hematoma, because of deep thrombocytopenia and DIC, but the patient was not with hyperleukocytosis. You can see that only 6,000 circulating leukocytes were there, with about 50% of circulating blast cells. My question to you for acute respiratory failure is, the probability of having pulmonary infiltrates from leukemia is 50%. Other patients may have infection or cardiac pulmonary edema. Do you think it's true? This probability of leukemic infiltrate is even higher if the patient has circulating monoblasts. Is it true? We should consider hematology as an emergency much more than acute respiratory failure. Is that true? It is a leukostasis. Is that true? It's not an acute lysis pneumopathy. So how can we navigate across all this terminology and these words that seem to be specific to hematology, but are actually critical care words? So yes, of course, 50% of the patient at the time of the diagnosis of AML with pulmonary infiltrates have leukemic infiltrates. I will go to the details in the next slides. And of course, when there are circulating monoblasts, this is the typical feature for leukemic infiltration. The emergency here is not to treat the leukemia, but to stabilize the patient and restore oxygenation. It is not a leukostasis. To speak about leukostasis, 50,000 blast cells are required, even if leukostasis is constant when you are over 200,000 leukemic cells. And it's not an acute lysis pneumopathy that is defined by a respiratory condition that follows the chemotherapy, follows the administration of chemotherapy. Leukemic infiltrates are usually differentiated as infiltration in the right and leukostasis in the left. Leukostasis refers to a high number of circulating blast cells making a cellular hyperviscosity. This is really an emergency because, of course, you have all the other signs of leukostasis, and the emergency here is to provide hyperhydration and a very slow deleukocytation by reducing as slow as possible the number of circulating blast cells. On the opposite, when you have a leukemic infiltration, there is no hyperleukocytosis, or this is not part of the typical feature. And you can see here that only the veins and the lymphatic vessels are full of circulating blast cells, making clear that here you can safely administer chemotherapy, and when the patient becomes neutropenic, then you are sure that you can withdraw oxygen. Here, it's very important that you do a slow deleukocytation, and you will have a slow reduction in the number of blast cells Because if you administer the 3+7, which is the classic chemotherapy regimen for AML, you will turn that into lysis pneumopathy and the patient will get intubated. So classically, we make the difference between leukostasis, pulmonary infiltration, that it doesn't require a high number of circulating blast cells, and acute lysis pneumopathy that is always a complication of chemotherapy and always occurs at the same time than tumor lysis syndrome. Very clearly, we know that these patients can also have an infection or a pulmonary edema. So leukostasis is cellular hyperviscosity. Leukemic infiltrates are really a disease, a very focused, localized disease in the pulmonary septa. Lysis pneumopathy is more a critical care condition that is a diffuse alveolar damage. It's going to last for 2-3 weeks, and we know that these patients are usually intubated, where we are trying to avoid intubation in other patients. Here, this is the typical case of pulmonary infiltration in an AML with monoblast, and we know that the CT is very informative because you can see that only the septal lines are marked, making very clear that we don't have a leukostasis, we have a very focused disease that is a typical infiltration of the lungs. And this is the pathology of the exactly same results, where you can see that only the septal lines are actually involved by the circulating blast cells. Dexamethasone has been recommended in this situation, but the level of evidence is very low coming from retrospective studies. This is what we do, but we don't have a high level of evidence for that. So myself, I would not recommend it, but many of the hematologists are actually giving dexamethasone to avoid that it turns into lysis pneumopathy so that the patients cannot be intubated. Of course, when you have a leukostasis, you have the typical features of leukostasis with all the entire symptoms, and you know that much better than me. I'm not going to get into that, but very clearly, when you have a leukostasis, it's not only in the lungs, it's also in the other organ systems. These are the post-mortem data in patients dying from leukostasis, and we also know that this has the typical cytogenetic and molecular biology translation, and I'm not going to get into these details, but we know that these AMLs are very specific and are also a target for new drugs that are very promising in this indication. And this is the only existing experimental model of lysis pneumopathy, where you can see that the mouse are really deteriorated by the administration of chemotherapy when there is a very high level of circulating leukemic cells. I'm now getting to make the jump from AML to the entire situation of acute respiratory failure in patients with hematological malignancies. So respiratory distress, pulmonary infiltrates, and hypoxemia. And I'm getting into the details for this situation because very clearly we know that this is the first reason for ICU admission, 70% of the patients. And also the collaboration between hematologists and ICU specialists is very, very important. It's paramount for one reason. It's because there is a center effect. The mortality in this patient moves from 70% in centers with low volume to 35% to centers with high volume. Of course, high volume centers are those ICUs where there are also the hematologists. And if mortality can be reduced, it's because we are working together. The collaboration between hematologists and ICU specialists is mandatory to reduce mortality. This is demonstrated on a daily basis. There are studies showing when this dialogue is optimal, there is a reduction in mortality. And the colleagues from Brazil have shown that when a hematologist is able to go to the ICU on a daily basis, there is a reduction of mortality in the critically ill. We know that acute respiratory failure depends on whether there is a prolonged neutropenia. In patients with AML in induction chemotherapy or allogeneic stem cell transplant, it's up to 50% of the cases, where it's much lower in patients with non-Hodgkin lymphoma or ALL. We also know that the major situation, the most important case is AML and MDS, leading to acute respiratory failure in up to 60% of the patients. Of course, at some places, the patients will be in the ICU, and in other places, they will stay in the hemato wards, but we know that there is a big difference in outcomes according to who cares for the patients. For a very simple reason. ICU is dedicated to the care of critically ill. When you have such patients in the wards, not only this patient has less experienced people surrounding him, but also the nurses are overloaded by these specific patients, and the other patients have an altered outcome. So this is why we need to work together to select the right patients to the right place. I will not detail oxygenation strategies, because in my experience, whether you give standard oxygen, high flow oxygen, or non-invasive ventilation, it will turn into the same mortality. However, data are very promising, showing that high flow oxygen, because it delivers warmed and humidified oxygen, but also it's going to deliver an oxygen flow that surpasses the patient's flows. So if you give 50 liters per minute to a patient having a respiratory drive of 35 liters per minute, the sickest patients, so you can still stabilize the administration of oxygen and reduce respiratory rate. Only the patients with improvement of oxygenation and reduction of respiratory rate are the patients who will benefit from the strategy. And there are numerous. So this is why studies are showing that high flow oxygen might be better for reducing intubation in these patients. However, there is no impact on mortality. So why am I spending a lot of time to identify the cause of acute respiratory failure? It's because we know that it's a major determinant. We know that 15% of the patients will stay with an undetermined etiology, and their mortality is higher. Of course, we need to rule out bacterial, viral, pneumocystis infections, as well as invasive fungal infection. But some patients stay with no identified cause of acute respiratory failure. So this is why I really recommend to follow the 3 steps for these patients. The first step is to use what we call the GPS. The GPS is a clinical strategy at the bedside that we call the direct approach. I'm going to that in a few slides. The GPS allows you in 30 minutes to 1 hour at the bedside to assess the patient, the imaging, as well as the entire condition, discuss between hemato and ICU specialists, and say, well, this is very likely to be A or maybe B. So then you're going to treat early the patient and to identify what's the best diagnostic strategy, whether you would do an antigen test, or whether you would do a nasal swab, a nasopharyngeal inspirator, whether you would do a sputa or an induced sputa examination, whether you would rely on biomarkers, or whether you would do bronchoscopy and BAL. But of course, in these patients, it's not so easy. So GPS, then the diagnostic test, and then you will conclude on diagnosis. So the 3 steps are mandatory. This is the direct approach. We described it 20 years ago. It's the D, the I, the R, the E, the C, and the T. The D is the time since the patient has a leukemia, or has been transplanted, or has a neutropenia, or has a prophylaxis. The D is actually the time where you start thinking, and it's the day 0. The I is the type of immune deficiency. Is it neutrophil, B cells, T cells, macrophages, and monocytes, or sometimes humoral immunity? And of course, you will make a bet on a responsible bug according to the type of immune deficiency. R and T are imaging. I love very much looking at the chest X-rays, but I know that many of you are doing CTs, and the CT patterns are actually indicating also probabilities because you see really where it is, and you can decide on the test that will be helpful to make the diagnosis. The E is the discussion between hemato and ICUs on whether it is a toxic event, whether it is a specific infection because the patient has received fludarabine, ibrutinib, or another specific drug, or maybe sometimes it is related to the underlying malignancy and we need to implement chemotherapy or targeted therapy to really get out of this. And of course, ourselves, the ICU specialists, when a patient has acute respiratory failure and septic shock, we know that we are dealing with a bacterial infection. So this is why I'm really asking you to work with ICU specialists and turn the stories into clinical stories. Not only the chest X-ray, not only the underlying malignancy, not only the treatment, not only the specific features, but everything. And everything is really helpful to expedite the diagnostic procedure and gain time to identify the acute respiratory failure etiology. So this is why we are also always writing the stories based on the direct approach. And this is very much helpful to get to a clinical algorithm that gives you the probability for bacterial, viral, fungal, pneumocystis, or other acute respiratory failure etiology. Let me give you an example in acute myeloid leukemia. In red, you have patients with myeloid malignancies, and in blue, we have patients with lymphoid malignancies. Let's say in red, AML, and in blue, ALL. You can see that before any treatment, the reason for acute respiratory failure is mostly infiltration of the lungs. Whereas when you are in ALL, it's mostly an infection. When you start treating, you have, of course, the lysis pneumopathy in AML, but you still see a number of infections in ALL. And of course, you have the cytarabine-related infiltrates as well as the acute toxicity of the 3+7. Then in the tunnel of neutropenia, you are getting into invasive aspergillosis. And I remind you that in AML, there is a recommendation for giving prophylaxis. You can have also mucoral infection. And with the PCR, we see more and more patients with mucoral. You have the very complex viruses. And then after neutropenia recovery, you have a number of other events. So this is why the D is really giving you a framework for etiology. This is the I. I is for immunologic dysfunctions, and it can come either from the disease. You can have, for example, a myelodysplastic syndrome with neutrophils that may be present or not present, but that their functions are really very altered. You can have also the treatments, and we spoke about ibrutinib, but you can do that for other drugs like anti-CD32 antibodies, or sometimes other drugs. We spoke about ibrutinib, but also rituximab, etc., are giving a specific immunosuppression. So then, based on this immunological assessment, you will state whether it's mostly the neutrophils, monocyte and macrophages, B cells, T cells, or antibody-related immunosuppression, and you will make bets for the responsible bugs. I give you an example here for a patient coming to the emergency department with a just diagnosed a T-cell leukemia. And this patient has never been treated, but you can see that there is an obvious pneumocystis pneumonia that is related to underlying malignancy because it's a T-cell defect. And we know that in a T-cell leukemia, some patients here in this series of 214 PCP cases, 30 patients had never been treated, showing very clearly that the disease comes from the underlying immunosuppression, from the disease, and not from the treatments, and not from the steroids. Again, we use CT because we know that CT is very good to explore the interstitial space, which is the space between the alveoli and the vessel. And we know that there are also typical patterns that should be used, because with the patterns, we are able to assess the probabilities for a given diagnosis. For example, ground glass opacities, nodules, crazy paving, cavitations, pleural infection. So for everyone, you will have probabilities for bugs, but also what's the best way to assess the infiltrate and go towards a specific diagnosis. And this is very useful. So I love the chest X-ray, but I also use the CT because it's very efficient to identify what is going there and what will be the pulmonary infiltrate and how you will get to the etiology. I'm changing now to move to another condition, that is hyperviscosity. You remember that we spoke about cellular hyperviscosity in patients with acute myeloid leukemia and a high number of circulating blast cells. But here I'm going to speak about humoral hyperviscosity. And humoral hyperviscosity has been described in 1965, but it was already published in myeloma in 1930 and in Waldenström disease in 1940. We know very clearly that it is related to the relative viscosity of the monoclonal body, so IgM versus IgG. We know that IgM has a very high viscosity, so this is why 30% of the Waldenström disease is going to be diagnosed using hyperviscosity, whereas it's only 2 to 6% of patients with myeloma and IgG. We know, you know Waldenström disease much better than me, but we know that these very large pentamers of IgM have a very high intrinsic viscosity, and with only 5 to 6 grams of IgM, you can develop hyperviscosity, where you would need 60, 70, or 80 grams of IgG or IgA to develop viscosity in the myeloma. And again, this is the same for treating, because we treat hyperviscosity by removing the IgM or the IgG by plasmapheresis. Of course, we start steroids and the underlying treatment. But at the same time, we know that IgM is mostly only intravascular. So with only 1 to 2 plasmapheresis, you are going to remove everything, and then the patient will receive the treatment and will keep it for benefit. So only 1 to 2 consecutive sessions of plasmapheresis are very useful for IgM. For IgG, that are mostly intratissular, we know that it's going to be long to clear the IgG, and this is why we are not doing plasmapheresis every day. We are using 1 to 2 or 3 days plasmapheresis, but of course we give myeloma treatment, and then it's going to be controlled with maybe 1 week to 10 days. We don't measure viscosity anymore. Of course, you can do it in your chemistry lab, but what we do is fundoscopy. And this is the typical feature of hyperviscosity, with sausaging of the veins, disc edema, and retinal hemorrhage. And look, just after plasmapheresis, you can see that everything is going to be cleared. I remind you that we mostly give albumin for these exchanges, but when there are the retinal hemorrhages, we give 20% of plasma to avoid increasing the hemostasis troubles and avoid worsening the bleeding. Again, this is a very strange journal, but this is the only place where I did find these results. You can see that the viscosity can be reduced by 30% with only 1 session. So if you have an IgM, 2 sessions can be enough. But if you have an IgG, you will need to do maybe 2 or 3 plasma exchange in 1 week, not every day, for the time that it comes from the tissues to the vascular space. Again, fundoscopy is really the gold standard to assess hyperviscosity, and many of us are trained, or we are trained to get trained to fundoscopy to better understand all of this. And now the last part of my presentation is going to be on a very, very new condition, it's not new anymore because the first patients who were CAR T-cell recipients who came to the ICU were when you were developing the trials on CAR and CD19. And this is a typical case where we don't know. We are seeing a patient in the wards who is quite young, less than 60 years old, with a diffuse B-cell lymphoma, and who was refractory to 2 lines and 2 autologous stem cell transplants. So he was in bridge with CARs. So he had, the CARs were recovered, and he was in a situation where he developed a septic shock at the time he received lymphodepletion. So he was with a severe septic shock, but we never knew whether this patient was an ICU patient or not because he had a number of refractory courses of chemotherapy. But the patients received ICU care, fluids, norepinephrine, mechanical ventilation, and the diagnosis came that it was a bacterial sepsis from the catheter. The catheter was removed, and after only 4 days, he was discharged from the ICU, and 2 weeks later, he received the CAR T cells. This patient was seen in 2022, and today, he's alive in complete remission. We know that using cancer immunotherapy has been a game changer for us ICU specialists. Of course, in oncology, with the checkpoint inhibitors, we see only 1% of the patients, but they are numerous. And they receive a number of checkpoint inhibitors in melanoma, for example, so we see them, or we used to see them. But in hemato, of course, we see more patients, but they are less numerous. So this is why CAR T cells has been very, very important for ICU specialists. So these are the data on checkpoint inhibitors showing that 1% of the patients required ICU admission. And this is one of the meta-analyses showing the incredible results of CAR T cells in patients with ALL here. So for us, administrating CAR T cells is also a source of cytokines. And we know that not only because the CAR is expanding in vivo, and this is producing cytokines, but it is also fighting against the leukemic cell, and this is also producing cytokine. And this is why many of the patients are going to have a cytokine release syndrome. Some patients will be only febrile, and fever can be easily managed in the wards with not only, of course, paracetamol, but of course with tocilizumab, which is again the receptor of IL-6. But some patients do more than fever, and they would do, for example, hypotension and even a status of shock or acute respiratory failure because the amount of cytokines is very high. This is why when they are in a situation when they have more than simple fever, so they have either severe hypotension or hypoxemia, they come to the ICU for something that we can call a grade 3 CRS. And when we look at the outcomes in these patients, most of them in this series that we published 3 years ago were patients with lymphoma, but actually they were really quite severe at ICU admission, but with a very low mortality. We also learned to keep tocilizumab for the wards, but when the patients are with severe organ dysfunction, we start steroids, and when they are with severe neurological dysfunction, we start anakinra, blocking IL-1, but with very, very impressive results. Ourselves, the ICU specialists, we are aware of the advances that were made in oncology and hematology, and that these patients who are not dying anymore are alive, but they use ICU resources because they are very frail, they are young, they are very immunocompromised, and sometimes they need an ICU stay for a number of days. So this is why we look at all this data and we understand that we have to consider ICU admission as a non-binary situation. Some patients come for a full code status. We will provide them everything for all the time that is required. But some patients will come for a time-limited trial because we are unsure whether they can benefit from ICU care. So we are going to give everything for 7 to 10 days, and then we reassess not only the hemato condition, but also the critical care condition. Mortality is high, about 50%, but 50% of the patients survive, and these patients can really get cured from their underlying malignancy. Sometimes we admit patients early to the ICU because they have an early sepsis or an early acute respiratory failure. Sometimes we admit them because they are high risk of tumor lysis syndrome, of toxicity, of any deterioration. And sometimes we admit patients for palliative ICU management with only high flow oxygen or only vasopressors, but with no project of giving surgery, dialysis, mechanical ventilation, just to bridge the management to an early ICU discharge and helping somewhere to manage these patients. The consequence today, as I showed you at the beginning of my presentation, is when I was younger and I was in the emergency department or the wards, I was thinking on who can benefit from ICU admission. And I was looking at the 10-15% of the patients that I was admitting to the ICU. Today it's very different. I'm thinking on who cannot benefit from ICU admission, and for all other patients, I will either do a full code, a time-limited trial, an early admission, or sometime I will admit the patient because they are at very, very high risk of deterioration. The reason why we admit this patient to the ICU is because we want them to survive for long and to get cured from the underlying malignancy. These are data from Vienna in Austria. And of course, they compared AML patients admitted or not admitted to the ICU. And of course, ICU patients have increased mortality. This is obvious. However, when you look at patients discharged from the ICU, they have the same mortality rate than patients never admitted to the ICU and the same probability of getting incomplete remission. Ourselves, we use the ICU as a bridge to cure. The ICU is not the place for palliative care. It's the place for curative care. We can do a bit of everything, but 80-85% of the patients need to have a hope for cure and for prolonged survival. This is true for remission. This is also true for quality of life. And when you look at this data coming from Amsterdam, you can see that whether there are hemato in intensive care or intensive care but not hemato, quality of life is exactly the same, making clear that these patients have a place in the ICU. And when we look at them for long-term outcomes, not only it is substantial for quality of life, but also we have now possibilities to improve long-term quality of life in these ICU survivors. To conclude, and I'm at 37 minutes, we are today in situations where it's very common to have a hemato patient in the ICU. Survival has improved very much in the hemato ward and in the ICU. We know how to select the patients, and we'll never admit a patient who is bedridden to the ICU or who is palliative. But for many patients, we have goals of care, and we can really admit them and offer substantial care for them. We are also now fine-tuning the prognostic factors for mortality to better understand what is happening. And we need now to move in a situation where we look at the quality, and the quality indicators are very important to understand what we can do for these patients. I remind you that blood disease in the ICU is also a training course that happens every year in Paris in January. So if you're interested by more, please contact me. Thank you for your attention.
So thank you very much, Dr. Azoulay, for this insightful presentation. I am sure we'll have some questions. So again, do not hesitate to send your question through the chat. So as we write from the question in the chat, I have a first question regarding acute myeloid leukemia. It was the first part for the evaluation of the respiratory failure. You say that for the acute lysis, it was always when we start chemotherapy, but in some patients with hyperleukocytosis, we can have also some kind of spontaneous acute lysis. So how do you know if this is hyperleukocytosis or some spontaneous acute lysis?
Acute resistant pneumopathy is really something that can be targeted by chemotherapy in 99% of the cases. Of course, when I say chemotherapy, I also mention hydroxyurea and many other
Steroid.
situations. Yeah, even small drugs.
Mm.
Yeah, you are right. For a very, very small number of patients, you might see acute resistant pneumopathy without chemotherapy, and this is related to the tumor burden. But these patients usually have a trigger, and this trigger has been identified as a viral infection or maybe sometime a bacterial infection, but it's less frequent. But I agree with you, in a very small subset of patients, you can have resistant pneumopathy without chemotherapy. But let's make it simple and make acute resistant pneumopathy as a complication of chemotherapy.
So we have a question. So this is an anonymous people that says the utility of getting immature platelet fractions in patients with thrombocytopenia with severe sepsis with or without DIC.
The
So
utility of what?
of the image, so I sent of platelet. So to use, because we know the platelet you can send in a single platelet. On the day you can give a platelet as fraction of every 6-8 hours.
Yeah, I think that response to platelet transfusion is also something making a lot of noise currently, and we have ongoing trials on this specific domain. I must say that as far as you can meet the magic number of 50,000 platelets, it's okay. But I remind you that there is a diffuse alveolar hemorrhage, but we are not quite sure that providing platelet reduces the risk for pulmonary bleeding. One of the things that works quite well if the patient is intubated is to slightly increase the level of positive pressure because it has hemostatic implications. But at the same time, we make our best to maintain the platelets at 50,000 and to also provide fibrin when there is a DIC. But at this time, I cannot be sure that we have evidence to say that there is a transfusion strategy that reduces diffuse alveolar hemorrhage.
Yeah, we still have some things to learn. Yeah, that's true.
Of course.
So we have one question from Dr. Lopez Lorenzo that thank you for your outstanding presentation on regarding acute myeloid leukemia when you have the lung infiltration on the leukostasis. Just to say that this is also, of course, we are going to do all the supportive care of the intensive care unit, but we need also to start the chemotherapy very quickly. So do you agree on that?
Yeah, but this is two different situations. If you have an infiltration, so the patient is not hyperleukocytic, you know that you are going to give the routine chemotherapy to the patient, and as soon as he becomes or she becomes neutropenic, the respiratory problem will be solved. However, if the patient has a leukostasis, I really urge you to avoid giving the classic chemotherapy regimen. I would do hyperhydration. With only hyperhydration, you can reduce the number of circulating blast cells by 20%. We are also giving hydroxyurea. I know that some of you might consider doing leukapheresis. I don't do that. But the literature is very ambiguous about that. We give steroids, but the level of evidence is very low. When I was in the lab, we just observed that giving steroids inhibits the adhesion of the blast cell to the pulmonary endothelium. But, we don't have a trial. The level of evidence is low. It's an AML, so it's not a classic indication for steroids, and it increases the risk for fungal infection. So we do it. We are very parsimonious. We are very careful because avoiding intubation is also a challenge. If you give classic chemotherapy regimen to a patient with 250,000 circulating blast cells, I wouldn't say that you are sure that he or she is going to be intubated, but I'm saying that.
Yes, to start slowly, just to reduce the hyperleukocytosis before doing the conventional chemotherapy, so the patient have time to improve.
Yes.
And we know also that regarding the leukostasis, there is also some involvement of the central nervous system. Do you have any recommendation regarding that?
Well, to be very honest, I live in a different world than you. So there are three recommendations that I would do. First, it's about transfusion, red cell transfusion. Don't provide red cell transfusion to a patient with hyperleukocytosis, because then you are quite sure that you are going to increase the rheology and increase the viscosity with brain bleedings.
We agree on
Unfortunately, we see that every year, and it's very unfortunate, but I must mention, I don't know if everyone here is a hematologist, but I have to mention that. The second thing is to be very clear. When there are neurological abnormalities, a CT scan with no injection is required to see whether the patient has a cerebral bleeding. It's very easy to do, and it's very easy because it's going to then make big differences in the way we are going to treat the patient. And number three, I think that we should limit the procedures in these patients. There is a number of things that we are not doing anymore. Why doing a bronchoscopy and BAL? We did that for years, and we were retrieving blast cells in the alveoli, and there is no interest. So we stopped doing that. We stopped doing aggressive procedures, and we are just getting slowly to reduce the blast cells until the patient is stable, until we have sometimes molecular biology or cytogenetics, and until we decide that when the patient is stable, has 20,000 blast cells, so then we start the chemotherapy, and the patient stays in the ICU until he is better. I know that you are not using an ICU bed for these patients all the time. I just urge you that it happens that this patient worsen with chemotherapy, and these ICU beds don't belong to anyone. So if you can use them for one day, or maybe just be in contact with the ICU people. I know that in some countries, the number of ICU beds are very scarce and we cannot use them easily. So just, in these countries, Italy, for example, ICU specialists are very much going out of the ICU to see the patients and care for them. So we just need to work together. I think that working together is the key word.
Yeah, and this is a really important front that, yes, you really need to talk, to discuss the patient, to see them together, even in the intensive care unit or in the hematology department, and we have a lot to learn from you. We have a very basic question. If you have a patient with a septic shock, are you going to remove the central catheter systematically, or are you going to wait for the blood cultures and
So the situation is without specific guidelines because the level of evidence is low. What we do is when the patient has neutropenia and septic shock with no respiratory involvement, no colitis, nothing in the skin and the soft tissues, we really consider that the catheter is the culprit. If the patient receives vasopressors, we would take out the catheter. If the patient doesn't receive the vasopressors, so then we would wait for the blood cultures to take out the catheter.
Yeah, so yeah, very simple answer. So I think we have to end now. We have still some questions, but it's difficult to take all of them. So I would like to thank you again, really close to these really insightful webinars. I want to thank you again for your time today. I want also to say that it was really a great presentation.
Thank you.
That goes through the details of a very difficult and complex topic. So I think your discussion today on the management of blood cancer intensive care unit is inspiring. You were able to show how we can navigate through hematology on intensive care units, critical care. It's not always easy. And you highlight that this is very important, that we work together, that we discuss, that we see the patient together at the bed of the patient, not only in staff, and this is very the key. So as we leave the session today, I would like to encourage all of you to reflect on the strategy that we share, that we discussed today, how it can apply for your routine practice and the daily practice, and to enhance your communication with your colleagues, and really to work now with the intensive care unit setting. So on behalf of everyone here, thank you again, Dr. Azoulay, for your contribution. It was inspiring. And I would like to thank you, all of you, for your participation for this webinar, for your commitment to advance the care in the field of hematology and intensive care unit. Have a wonderful day, and I look forward to see you very soon to the next educational event. Thank you.
Bye-bye.
And goodbye.